So let's now talk about the physiology of the aqueous humor formation and the intraocular pressure. In this lecture, we will talk about what are the functions of the aqueous humor and the composition of the aqueous humor and what will be the dynamics, how it is formed and how it is drained. So it will be the mechanism of formation and outflow of the aqueous. Then the blood aqueous barrier, and finally we will talk about the intraocular pressure. So you may find that there is a similarity in the construction or in the outline of the aqueous layer and the lacrimal layer, and there is a similarity also in the outline between the cornea and lens, and that's why every two groups or every two lectures are grouped together. So let's start immediately with what is aqueous. Aqueous, we know it is the clear fluid that is present in the anterior chamber between the lens and iris posteriorly and the cornea anteriorly. So here is the aqueous humor, which fills the space of the anterior chamber and posterior chamber. The main functions of the aqueous humor that it brings oxygen and the nutrients to the cells of the lens and the cornea and the iris. So we said that this is the main source of glucose and also one of the sources of oxygen that's present to the cornea, and it is the main source of oxygen present to the lens. So this will be the one of the main functions of the aqueous humor, that it has it cause nutrition or it supply nutrition to the structures of the eye. Also, it will be responsible for removing the waste products from the metabolism or the metabolic process present within these structures. So if there is any waste products coming from the lens, like the lactic acid, it will be removed by the aqueous, and as well as from the cornea, any waste products from the metabolism of the endothelium, it will be removed by the aqueous. It has an optical function, as it has a refractive index of less than the cornea, so it will cause slightly diffraction, or slightly divergence of the light rays. But it will, together with the different optical media of the eye, it will focus the light on the retina. It will provide a medium that will inflate the globe, and it will be responsible for the maintaining intraocular pressure. If we don't have aqueous, the eye will be doughy, or the eye will be very, very, very soft, as there is nothing that will fill the eye. It has some important components or some important products like the ascorbic acid, which act as an anti-free radicals or antioxidant. So it will protect the lens from the damaging effect of the free radicals. So we said that the ascorbic acid is present like 50 times in the higher concentration, because it has a main antioxidant effect. And also, since it will be formed by different mechanisms from the ciliary body blood vessels, these ciliary body blood vessels will be also responsible for bringing antibiotics for inflammation or infection. So this will facilitate the cellular and humoral response of the eye by bringing antibodies and antibiotics. Some physiological properties about the aqueous: it has a volume of about 0.3 milliliter with a refractive index of 1.3, so it is less than the cornea. pH is 7.2. The osmolarity is slightly higher than the plasma, and the viscosity and density are slightly higher than water, and the rate of formation is between 1.5 to 4.5 microliter per minute. Again, let's come to the composition. So this is again one of the important slides to concentrate and to remember in this within the context of the aqueous. So water, it's about 99%, so it will be more or less like the tear film. It will be, both will have the same content of water. The protein content is about 5 to 15 milligram per 100 milliliter. So this concentration is very, very, very low, because it's only 0.2% of the plasma concentration. So Remember that the protein is present in very minimal amounts within the aqueous. It is not abundant, and also it is not absent, because this has appeared first in the MCQ questions of the ICO, asking about if the aqueous is lacking protein or if there is no protein in the aqueous, and the answer is no, because it has very minimal amounts. Glucose has a 75% of the plasma concentration, and this is as it is again, it is the as the tear film, it is lower than the plasma concentration because it is rapidly consumed, while the lactic acid and the pyruvic acid are increased, and these are metabolic products from the aerobic and anaerobic glycolysis present in the lens and the cornea, so that the lens and the cornea get rid of them and they are removed into the aqueous. So they increase in the aqueous by diffusion from the lens and the cornea. For the electrolytes, the sodium will be the same. So this will be a common cation that's the same in the lens, same in the aqueous and the plasma, and also it is the same in the tear film and the plasma. The bicarbonate ion will show decrease its concentration into the anterior chamber, and the hydrogen and the chloride will be more than the plasma. So this will be the same as in case of tear film. The phosphate concentration will be less than the plasma. And the ascorbic acid, as we said, it will be very high. It will be like 50 times in aqueous more than the plasma. So these are the main composition or the main contents of the aqueous, and what are their ratios. So to summarize, what are the things that increase in the aqueous humor? So water will be about 99%. Lactate and the pyruvate will be more due to waste products coming from the lens and the cornea. Ascorbic acid will be 50 times more, as it will be one of the main antioxidants within the lens. Chloride and the hydrogen will be diffusing passively, as we will see later on. While the protein content is decreasing, but it is not absent. Glucose also is decreasing due to it's highly consumed by the lens and the cornea, and the bicarbonate and phosphate are also decreased. So these are the main electrolytes and their percentages and their ratios in relation to the plasma. And the sodium will be again the same between the aqueous and the plasma. So after we know now what is the composition and what are the functions of the aqueous humor, let's now discuss what are the dynamics, how it is formed, and how it is excreted or how it is drained from the eye. So we all know from the anatomy that it is produced by the pars plicata. So the pars plicata is the anterior 1/3 of the ciliary body, which is the pars plicata is what's called the ciliary process. So the ciliary process are the part of the ciliary body that is responsible for formation of the aqueous humor, and it consists from two types of cells. There is a ciliary, the ciliary epithelium is two types. We have the non-pigmented ciliary epithelium, which is on the inner side, and the outer pigmented epithelium, which is on the outer side. The aqueous is formed by the non-pigmented ciliary epithelium. So the non-pigmented ciliary epithelium will be the epithelium which will be on the inner side toward the posterior chamber. So that this will be the cells responsible for aqueous humor formation, and this will be under the effect of the beta adrenergic receptors. So the aqueous formation will be under the effect of beta adrenergic receptors. So stimulation of the beta adrenergic receptors will cause increased aqueous formation, and that's why if the patient takes beta blockers, this will lead to decreased aqueous production and leading to decreased aqueous formation and decreased intraocular pressure. And also to mention that it also has another control by the alpha receptors. So the alpha receptors, if they are blocked or if they are antagonized, this will increase the aqueous production. So blocking the alpha receptors will cause increasing the aqueous production. That's why if we want to decrease aqueous production and decrease intraocular pressure, we give the patient what is called alpha-2 agonists. So alpha-2 agonists will antagonize the alpha receptor, causing decreased aqueous formation, while alpha-2 agonist will stimulate the alpha-2 receptors, causing decreased aqueous formation. But the alpha-2 blocking effect, or if we do alpha-2 blockers, this will cause stimulation, or the stimulation of the alpha-2 receptors, inhibition of the alpha-2 receptors will cause increase in the aqueous production. So here is the section for the lens and the ciliary body. You can see that there is an outer outer pigmented epithelium, this, which is outer toward the sclera, and we have the non-pigmented epithelium, which is on the inner side toward the posterior chamber here. So this will be the non-pigmented epithelium, which will be responsible for formation of the aqueous humor. This can be done within the ciliary process. So we know that we have about 70 ciliary process. The ciliary process has a core of stroma, or the ciliary stroma is present in the center, and the stroma has a connective tissue and the blood vessels. So from these blood vessels, or from the ciliary blood vessels, the process of filtration, or the process of formation of the aqueous humor is started to form. So this will be the blood vessels, or contents from the blood vessels will pass through to the pigmented epithelium, and some contents from the pigmented epithelium will pass to the blood vessel, and then there will be also an exchange of molecules between the non-pigmented and pigmented, and then the aqueous will be secreted from the non-pigmented into the anterior chamber. So what are the mechanisms responsible for formation of the aqueous humor? This is an area this is a topic that is characteristic to aqueous specifically. So we need to know about it and understand it, because since it is unique to the aqueous, it will be maybe asked in the exam. So the aqueous is formed by three mechanisms. The first one is called diffusion, or to say, let's rephrase it, to the different contents of the aqueous humor are formed by different mechanisms. So in order to reach the chemical composition of the final composition of the aqueous humor, this will be because that the contents of the aqueous are formed by different mechanisms. The first one is called diffusion. The second one is called ultrafiltration. The third one is called active secretion. So let's start. What is diffusion? If we have this a pot, and this is a semi-permeable membrane, and this semi-permeable membrane separate two sides. In each side there is a fluid, or let's say it's the water, and salts. In one side the salts are few, and the other side the salts are much. So what will happen? According to the concentration gradient, by time the salts or the molecules will pass across this semi-permeable membrane to the other side, so that the concentration will be equal on the both sides. So this occurs, or this is one of the mechanisms of formation of aqueous humor. As aqueous pass through from the posterior chamber to Schlemm's canal and comes in contact with different ocular structures, then there will be diffusional exchange. So as the aqueous is passing, it will pass through different ocular structures. So according to the diffusion mechanism, or there will be exchange between the solutes and water between the aqueous and these different ocular structures, until they reach a balance. They reach a balance of the solute concentration on both the aqueous and the different ocular structures. So that eventually the aqueous will be more or less resembling the plasma. So its salt contents will be more or less like the plasma, if this is the only mechanism that will form the aqueous humor. But there are other mechanisms. The second mechanism is called the ultrafiltration. Let's again have the same example, that this is a pot and this is a semi-permeable membrane, and these are some solutes here and there are some solutes there, and so these solutes can move by concentration gradient from higher concentration to lower concentration. There is another mechanism that will cause moving of the solutes, but in this condition it will not pass by concentration gradient but by pressure gradient. So if we apply pressure at one side, this will lead to movement of the solutes from one side to the other side, and this pressure will be exerted by the proteins. So if there is a proteins like that of the plasma, so if there is a plasma protein cause hydrostatic pressure, and this hydrostatic pressure will cause moving of the solutes from the plasma into the aqueous. So again, this is a mechanism of formation of the aqueous humor by pressure gradient and not by concentration gradient. So ultrafiltration, the solutes are moving through a semi-permeable membrane by a pressure gradient. So this amount of moving can be increased by hydrostatic pressure on the protein-rich side of the membrane. And in case of the plasma has high oncotic pressure, high hydrostatic pressure. It's about 50 to 60 millimeter mercury, compared to the normal intraocular pressure, 10 to 20. So this hydrostatic pressure will cause solutes to pass across the capillary wall to the ciliary body, to the pigmented, then the non-pigmented ciliary epithelium. So is that all? These are all the mechanisms? The answer is no. We have another very important mechanism and responsible for formation of the most of the aqueous humor, which will be, let's see in a while. So to summarize, the difference between the diffusion and the ultrafiltration, that in case of diffusion, the solutes are moving by concentration gradient. So the solutes will move from area of high concentration to area of low concentration until balance occur. But in case of ultrafiltration, there doesn't have to be a concentration gradient, and there doesn't have to be a balance between both, because since there is a pressure that is exerted by the protein high side, this will lead to moving of the solutes across the semi-permeable membrane just by pressure gradient. So it will be just under the effect of the pressure. The third mechanism is called the active transport. And as we know from the cornea, from the lens, that the active transport doesn't respect any gradient. So it doesn't respect the concentration gradient, it doesn't respect the pressure gradient. It is just an energy-dependent process that will make the cell or will make the tissue take whatever it needs by just the energy. So in such a condition, the aqueous use the active transport in order to selectively move some substances against the electrochemical gradient across the cell membrane. And this will be the major or the main mechanism responsible for formation of the aqueous humor. So they are mainly formed by the active transport. It is present by it is done by the non-pigmented ciliary epithelium. And in this case, the sodium is pumped across the cell membrane, while the chloride ion and the water passively carried out to maintain the electrical and concentration balance. So in this condition, the ciliary epithelium or the non-pigmented ciliary epithelium push out the sodium, and the water and the chloride will follow passively, so that this will cause increasing the sodium and the chloride and water within the aqueous humor, and this will be the main mechanism responsible for making the aqueous humor. So this is the diffusion moving against the concentration gradient. This is the ultrafiltration moving with the pressure gradient. And this is the active transport. So you can see, although that the molecules here are less than in the other side, but with the use of the energy, this concentration gradient can be skipped, and the molecules can be moving from the lower side to the higher side. So what is the summary of the process that occurred in order to form the aqueous? So let's suppose that this is the posterior chamber, and this is the processes that occur within the non-pigmented ciliary epithelium and the pigmented ciliary epithelium. So the pigmented ciliary epithelium will be in conjunction with the blood or the ciliary blood vessels. So we'll repeat what we have said in the cornea and the lens. So the CO2 and the H2O will join together using the carbonic anhydrase enzyme to form the H2CO3 or the bicarbonic acid that later on will dissolve to bicarbonate and to hydrogen. The bicarbonate will dissolve or will diffuse into the blood, while the hydrogen will be exchanged at the hydrogen sodium exchanger, so that the hydrogen will be moving toward the blood, while the sodium is coming from the blood into the pigmented, then the non-pigmented ciliary epithelium. Then through the sodium potassium ATPase pump, the sodium is pumped out from the non-pigmented ciliary epithelium and take the water passively with it, and this will be in exchange with the potassium that will enter through to enter the non-pigmented ciliary epithelium. So this will be the same process like we discussed before. To see it on this illustration, this is the stroma, and this is the pigment epithelium, and this is the non-pigment epithelium. You can see that the CO2 and H2O will form into H2CO3 using the carbonic anhydrase that will later on dissolve to the bicarbonate, which will move to the blood. And the hydrogen will be exchanged with the sodium through the sodium hydrogen exchanger. Then the sodium will enter through the cell from the pigmented epithelium to the non-pigmented epithelium, where it can be exchanged through the sodium potassium ATPase pump, so that the sodium will exit from the non-pigmented epithelium, taking the water passively with it, and it will leading to that the potassium will enter through the cell, the non-pigmented epithelium, to maintain the balance. And this process will be energy dependent, as the sodium potassium ATPase pump is dependent on energy. And as you can see, this is the molecule called, or this is a drug called the ubiane that I told you about before, that will inhibit that can inhibit the function of the sodium potassium ATPase pump. So this is the process of formation of aqueous humor regarding the active process or active secretion of the aqueous humor, depending on the sodium potassium ATPase pump and carbonic anhydrase enzymes. So these are the main enzymes that will control the active secretion of the aqueous. If any one of them is blocked, then the rate of aqueous formation will be decreased. That's why we use the carbonic anhydrase inhibitors as an anti-glucomatous drugs, because they will block the carbonic anhydrase, so they will block the the aqueous formation, leading to decreased aqueous formation and decreased intraocular pressure. The sodium and the ascorbate are transported from the plasma to the posterior chamber, while the water and chloride follow passively to maintain the electrical and the concentration gradient. Amino acids are also one of the important molecules that are actively transported, as we said in the lens, so that it will also actively transport, and will be also in the aqueous will be actively transport. And just small molecules that will cross the aqueous by diffusion. So, as I told you, how can we decrease the aqueous formation? Having known this, we will now know how to decrease the aqueous formation using one of these enzymes. So if there is a inhibition of the carbonic anhydrase enzyme like diamox, this will cause decrease of the aqueous formation. If there is metabolic acidosis, this will cause inhibition of the sodium potassium ATPase pump and sodium potassium ATPase enzyme. So this also, the metabolic acidosis, can cause decrease of the intraocular pressure. So this is about the aqueous formation. Do you have any question in it? Okay, so we now know how the aqueous was formed, and then it will circulate within the posterior chamber, then it will reach the anterior chamber through the pupil, and now it wants to be drained outside the eye. So this will be what's called the aqueous outflow. So how does the aqueous leave the eye? As we know, the aqueous will be secreted from the ciliary epithelium, lining the ciliary process, and then it enter posterior chamber, flow around the lens and through the pupil to reach the anterior chamber. Then the aqueous itself will undergo what's called convection current. What is the convection current or convection flow within the anterior chamber? There is a temperature gradient, meaning that if we have here, this is the cornea, and this is the iris. Here is the iris. When the aqueous is passing from the posterior chamber through the pupil to the anterior chamber, it is in contact with the iris, and the iris has surface blood vessels. These blood vessels will make that the aqueous become warm. So once it is warm, then it will sink down. So the aqueous will move down, and then there will be the aqueous outside or away from the just hold on, please. Okay, the aqueous away from the iris will be cold, so it will be cold here and here and here and here. So this will lead to a current or a current that will be circulation of the aqueous from above to below. Let's see this in the video. This video that I have, this what I have filmed on my patient that has show this convection current. So you see that this patient has cells in the anterior chamber, and you can see that the cells are floating above in the aqueous, which is close to the iris because it is warm. So it will increase upward or move upward. I guess I confused in the last slide. So the warm aqueous will move upward, and here is the aqueous, which is just behind the cornea, will move downward. So there will be a current inside the eye. This current caused by difference in the temperature of the aqueous from the surface of the iris or anterior to the iris and to the back of the cornea. Okay, so what happens next? After the aqueous circulates within the anterior chamber, then it wants to leave the eye. Then we have two main pathways that the aqueous will leave the eye from. Either the conventional pathway, or what's called the trabecular pathway, or the non-conventional pathway, or the uveoscleral pathway. The conventional pathway is the main route for leaving the eye. So it will like about 90% of the aqueous will be removed from the eye through this route. It will pass first through the trabecular meshwork, then through the inner wall of the canal of Schlemm, then its lumen, then the collector channel, and the aqueous veins and episcleral veins. So this will be the conventional pathway. But the other pathway, which is called the uveoscleral, accounting for about 10 to 30%, the aqueous will be absorbed through the iris root, then it will go to the uveal meshwork, then the anterior surface of the ciliary muscle, and the connective tissue between the muscle bundles to the suprachoroidal space. So it is like a shortcut. So let's see this. Here is the aqueous secreted from the ciliary epithelium, passing through the posterior chamber, then the pupil, then the anterior chamber. Then it will pass either 90% will pass through the trabecular meshwork, causing in the trabecular meshwork, then the inner wall of the canal of Schlemm, then the lumen, then into the collector channels and the aqueous veins, and finally into the episcleral veins and subconjunctival space. Or some of the aqueous may escape through the iris root, passing through the anterior surface of the ciliary muscle and the connective tissue between the uveal tissues until they reach the suprachoroidal space, so that they are drained. To differentiate between the aqueous outflow or the different routes for the aqueous outflow, the trabecular flow is between 75 to 90%, while the uveoscleral flow between 10 to 30%. Well, this will depend mainly on the age of the patient. So the younger the age of the patient, the more the uveoscleral; the older the patient, the less the uveoscleral. The trabecular flow passes through the canal of Schlemm and episcleral veins, while the uveoscleral passes through the ciliary body and the choroidal vessels. Trabecular flow will be increased by myotics and accommodation, as they will cause contraction of the ciliary muscle, which will pull on the ciliary spur, leading to opening of the trabecular meshwork, as we said in the anatomy, so that so this will be increasing the trabecular outflow, but it will be decreased by the reverse. So the anticholinergic drugs such as atropine will cause relaxation of the ciliary muscle and crowding at the angle, causing clogging of the trabecular flow. The reverse will occur in the uveoscleral pathway, so it will be decreased by myotic and increased by atropine. So that in case of atropine, there will be the more crumpling of the iris at the edge of the angle, so it will increase the surface area for absorption and increase the area of the uveal meshwork or uveal tissue for absorption of the aqueous. And also it can be increased by prostaglandins, maybe due to a mechanism related to what's called MMP or metalloproteinase enzymes or matrix metalloproteinase enzymes, and apraclonidine, which is an alpha-2 agonist. Then we come to another important area, which is what's called the blood-aqueous barrier. The blood-aqueous barrier is a barrier that is present between the apical portion of the non-pigmented ciliary epithelium, so that it will selectively choose what to enter within the aqueous and what not to enter to aqueous from the plasma. So different contents can pass from the plasma to the pigmented ciliary epithelium to the non-pigmented ciliary epithelium, but since there is a tight junction between the apical portions of the adjacent non-pigmented ciliary epithelium, this will prevent further passage of this unwanted contents from the plasma to enter through the posterior chamber. And this also will be responsible for maintaining the difference in the chemical composition between the aqueous and the plasma. So here you can see that this is the fenestrated capillary endothelium, which will make a part from the tight junction, and the tight junction between the non-pigmented ciliary epithelium, which will form another part from the blood-aqueous barrier. So here, both of them, the capillary endothelium and the tight junction between the apical portion of the non-pigmented ciliary epithelium, both together will form what's called the blood-aqueous barrier, which will have a selective function to select what to enter to the aqueous. And as we said, it will be responsible for the difference in the chemical composition between the plasma and the aqueous. So when does the blood-aqueous barrier break? In some conditions, such as intraocular inflammation or uveitis, this will lead to break of the blood-aqueous barrier. And this can be something beneficial or harmful. It is beneficial because if we have infection, or if the patient, for example, has an infection or uveitis, breaking of the blood-aqueous barrier will cause the antibiotics to pass from the plasma to enter through the anterior chamber or to reach the aqueous, so it will have a therapeutic effect. But on the other hand, it can be problematic, so it will interfere with vision, as it will lead to passage of the plasma proteins to the aqueous, and also it will cause a passage of the microorganisms or other harmful products to the aqueous. So the break of the blood-aqueous barrier can manifest itself through several ways. I think that we saw this video before. This is the cells and the flare. So the flare is basically, let's see if I can play it from here. Doesn't play as well. It's okay. So the flare is just what is making is made from the plasma protein. The flare, which appears like smoke in the anterior chamber, is formed by plasma proteins which broke the blood-aqueous barrier and entered to the anterior chamber. There are different materials that can cause break of the blood-aqueous barrier. Some are traumatic, some are physiologic, some are pharmacological. So you just have a quick reading through them. And just to need to know what are the beneficial and what are the harmful effects of the blood-aqueous barrier breaking down. So this will cause bringing the humoral and the immunity or the cellular and humoral immune responses. So it will cause bringing the immunoglobulins and the antibiotics to the anterior chamber. So this will be a good effect, but it will cause increased protein contents, causing increased synechia formation. And the Tyndall effect. The Tyndall effect is an optical phenomenon, has a physiological principle. So optical phenomenon here is the scattering of light. Scattering of light occurs due to a physiological basis, which is accumulation of proteins within the anterior chamber. So if there is, this is the eye, and this is the anterior chamber, and this much protein within the anterior chamber. When the light rays will hit the anterior chamber, this will cause scattering of this light. Scattering here is caused by as the proteins are act as they are particles present in the anterior chamber, so they will cause a scattering of light. This is called Tyndall effect. Also, if there is a breakdown of the blood-aqueous barrier, this will lead to affection of the active transport, so that decrease the aqueous production and decrease the intraocular pressure. Now let's move to the intraocular pressure. What is the intraocular pressure, how it is measured, and what are the factors that will control it? So the intraocular pressure is the pressure exerted by the intraocular contents on the eyeball. It is normally between 10 to 21. So this is the normal range, being that 10 will be the lowest and the 21 will be the highest level of the normal range. It is this pressure is maintained by an equilibrium or a balance between the aqueous inflow and the aqueous outflow. So the rate of aqueous formation should be balanced with the rate of aqueous drainage, and both of them will have some balance, leading to that they will form the normal intraocular pressure. So what will be the factors that will control the intraocular pressure? These factors have been summarized by or illustrated by Goldman. So the Goldman has made an equation that will control will assess the relationship between the different factors that will control the intraocular pressure. So he said that the pressure inside the eye, which is the PO, or the pressure ocular, will be equal the rate of aqueous formation, which is F, measured in milliliter per minute, divided by C, which is the facility of the outflow, plus the PV, or the pressure of the episcleral veins. So from this equation, we have three factors that will control the intraocular pressure. The first one, how much the aqueous is formed. The second one, how much resistance that the aqueous will face, which is the facility of the outflow. Is it high or is it low? The third will be the episcleral venous pressure. So the resistance to the aqueous and the episcleral venous pressure will counteract the intraocular pressure, or will cause increase the intraocular pressure. So if they increase, this will cause increase of the intraocular pressure. And if the rate of aqueous formation is increased, this will cause increase of the intraocular pressure. But from this equation, what will be the most single factor that will be affecting the intraocular pressure? Will be the episcleral venous pressure? Well, the answer is no, because there is a plus sign here, meaning that if the episcleral venous pressure increase by 1, the intraocular pressure will increase by 1. So it doesn't have a tremendous role. The aqueous formation also doesn't have a tremendous role, but here the aqueous facility will be the main governing factor for the intraocular pressure, because it will be, if there is a slight decrease or slight increase in the resistance to the aqueous outflow, will cause much difference in the intraocular pressure. So remember that the outflow will be the main factor that will control the intraocular pressure. So from here, we know that if we want to decrease, as an anti-glucomatous drug, if we want to decrease the intraocular pressure, we need to either drugs that will cause decrease of the aqueous formation, or drugs that will increase the aqueous outflow. Or if there is any mass or pressure from behind the eye that will cause increase in the intraorbital pressure and increase the episcleral venous pressure, this should be removed first, because there is no meaning to decrease aqueous formation or increase the outflow, and there is a mass or carotid cavernous fistula or whatever lesion that will cause much increase in the episcleral venous pressure. So how can we measure the intraocular pressure? This can be done through one of two methods. The first one is called the manometry or the tonometry. The manometry is the true and real measurement of pressure, meaning that if we are speaking theoretically, in order to measure the pressure inside the eye, we need to pass a needle. This needle should be attached to the sphygmomanometer, like this. So this is a mercury, and then this mercury should be elevated according to the pressure inside the eye. So it should be elevated about 15 or 20 millimeter mercury. So this will be the normal, or the real and the true measurement of the pressure inside the eye, by how much the pressure inside the eye will displace a column of mercury along a scale. But actually this is not feasible, or we cannot do this in routine practice. That's why we refer to another indirect method to measure the intraocular pressure, which is called the tonometry. So the tonometry is an indirect measure of the intraocular pressure using an instrument called the tonometer. The tonometer has different types. So one of them is called the indentation. So it will act by indentation. And the other is called applanation, which will be acting by applanation, as we will see now. The famous example for indentation tonometer will be called the Schutz tonometer. While there are different models for applanation tonometer, they are all work by the same principle. So we have the Goldman applanation tonometer, we have the Perkins tonometer, which will be the portable version of the Goldman, we have the tonopen, and we have applanation by an air puff or air jet, which is called the non-contact or air puff tonometer. Let's start by the indentation tonometry. In the indentation tonometry, we use a plunger. This plunger will indent the soft eye more than the hard eye. So basically, the basic principle that if we put this plunger or this plunger will displace the cornea, and by putting a weight, this will cause more displacement of the cornea. So this will enable us to know what is the pressure inside the eye by as we this amount of displacement will be counted on a scale, and as this scale will be moving, or this pointer will be moving through the scale, we can take this figure and correlate it with an intraocular pressure reading. So this is called the Schultz tonometer, and has a plunger that will indent the soft eye more than the hard one. It has advantages that is inexpensive and portable and easy to use, but it is limited in accuracy in some conditions like high myopia and the following surgical procedure or corneal edema. This is how does it look? The Schultz tonometer. We hold it from here, and then apply this foot plate over the cornea and apply weights here until we reach a scale recording, and then we compare this scale recording to a table with an intraocular pressure measurements. So here, this is the curved metal foot, and this is the metal plunger, and this is the frame with the handle that we use for holding this device. This is the numerical scale and the indicator needle and the hammer, and these are the weights that are placed here. So these are variable weights. Let's assume, for example, we are now putting a weight of certain amount, and then the scale is pointing to 30. Then we compare this 30. This is not the intraocular pressure, but we just compare this to another intraocular pressure reading through a table. This is a table. So we put it like there, we put the weight. So if we put, for example, the weight is 5.5 gram and the scale reading is 10, then the pressure inside the eye is 7.1. There are some limitations of use of the indentation tonometer or the Schultz tonometer, because it's sometimes produce some errors, like errors in the calibration of the instruments, or errors due to contraction of the extraocular muscles or accommodation, which cause increase of the intraocular pressure, or if the eye is too rigid, or it is too soft, or if there is any variation in the corneal curvature, or affection or errors in the scale reading, or there is a blood volume alteration. From here, there is a need for another device, and this one is the gold standard for measurement of the intraocular pressure, which is called the Goldman applanation tonometry. The Goldman applanation tonometry is based on the applanation tonometer principle, and this is called the Embert-Fix principle. We said this in the slit lamp, and we will repeat it now. So what does Embert-Fix say? It says that if there is a pressure, to measure the pressure inside the sphere, which is referred to P, so this will be equal to the force applied to this sphere in order to flatten a surface area. So this surface will be called A. So pressure inside the sphere will be equal the force applied divided by area flattened. So in order to know the pressure inside the sphere, you have two variables here. One is the weight, and the other is the area. So you need to fix one of them, either to make a variable force and fixed phase, or fixed area, or to make a variable area and fixed weight. In case of measuring of the intraocular pressure, it's much easier to make the weight variable and to have a specific flattened area, or a specific measured flattened area. So here, when we apply the applanation cone, the W, or the force which will be applied to the cornea, will cause applanation of the cornea, making it like a plane surface rather than the spherical surface. And this applanation should applanate a specific area. This area, according to the imperfect principle, it is 3.06 millimeters. You have been asked about this in the optics exam. So we fix the area, and now we can change the knob from here in order to apply much force over the eye until there is applanation of this part of the cornea, which is equal 3.06 millimeters. We will not go through much details about the pterometer. This has been discussed already in the optics. But there's just to know that this is the tip that will applanate the cornea, and this is the knob that will control the power or the force applied to cornea in order to have an indirect measurement for the intraocular pressure. Here is the process of applanation tonometry. So we have mentioned before what are the fallacies, or what are the false positive, false high and false low. So if we have a thin cornea, this thin cornea will yield easily under the effect of the tip of the cone, so that this will cause underestimation. Or if there is a thin Myers by the fluorescein, or if there is corneal edema, as the cornea will be spongy and soft. Also, it can cause false high or overestimation if there is a thick cornea. So the cornea is very thick, and we need to apply much more pressure in order to applanate it. Or if there is a thick Myers by fluorescein, so we need to dry the tip and dry the patient's eye to decrease the pooling of the fluorescein. Or if there is corneal scar, so although it will cause corneal thinning, but the scar tissue itself is tough and will need much more pressure in order to applanate it. Another version for the applanation tonometry will be called the Perkins tonometer, and Perkins will be applied over the eye, and it will be the same by the same principle like the Goldman, but it is just portable. So it can be used for bedridden, but you can use it for children, for examination under general anesthesia. This will be the best choice. And to say, and for the record, the applanation tonometry using the Goldman or the Perkins are the most accurate measurement for the intraocular pressure so far. So they are most accurate from other measures, more than the tonopin, as we say. So the tonopin has a tip that we can put or we can apply it over the cornea by pressing over the surface of the cornea about 10 times until electronic measurements is recorded here. Is using a jet of air to applanate the cornea, and this can be used for screening, as it sometimes it doesn't produce a very accurate results. Finally, we come to the factors that will affect the intraocular pressure. We have several factors. Some will affect the long-term effect of the intraocular pressure. Some will affect the short-term. For the long term, we have the genetics, age, gender, refractive error, and race. So how does these factors will affect the risk of developing of the high intraocular pressure or development of glaucoma? Some people are born with a genetical susceptibility to glaucoma, or specifically for primary open-angle glaucoma. So those individuals will have high CD ratio or cup-to-disc ratio and have positive family history should be considered for glaucoma screening and for glaucoma management if they are proved to have high intraocular pressure and glaucoma. Age is also an important factor because most primary glaucomas occur at older age, because at older age the trabecular meshwork will be accumulating much more debris and cells all over the ears, so they are clogged and they are closed, and they no longer able to drain the aqueous. So this will be the commonest cause, one of the causes of why the intraocular pressure increases with age. In case of children, the child is not cooperative, so for some time the child may squeeze his eyes, causing to false overestimation of the intraocular pressure. The gender is also has a rule as since between 20 to 40, then there will be no much difference in the intraocular pressure between male and females. But as we get older, then there is a much increase or more increase in the intraocular pressure in females more than males. Races also have been associated with increased likelihood of increased intraocular pressure. So it has been reported that the primary open-angle glaucoma or the rise of the intraocular pressure much more common in the African American or the blacks than in whites. And also some other glaucomas. I don't want to go to the clinical, but it's okay. Refractive error also has a rule, so if the patient has myopia, they are more prone to develop primary open-angle glaucoma, and if they are hyperope, they are more prone to develop the angle closure glaucoma due to shallowness of the anterior chamber. So myopia have higher incidence of chronic open-angle glaucoma, while the reverse occur with hypermetropia. There are other short-term factors that will control the intraocular pressure. So let's start with them. First of all, the diurnal variation. It was reported that there is a difference between the normal intraocular pressure in the daylight and at night. So there I have several factors. We don't want to go through this. But to summarize, we have the most important that there is a difference between the intraocular pressure in the day and the night, about 3 to 5 millimeter mercury. This is normal. But in case of the patient is glaucomatous, or if the patient has wider fluctuation between the night reading and day reading, which will be about more than 10 millimeter, this is very suggestive of glaucoma. So a glaucoma is not a disease that can be diagnosed by a single intraocular pressure measurement. So the peak intraocular pressure is in the morning hours and become high in the morning and decrease at night. This is called diurnal variation, so this is a short-term fluctuation. Postural variation, also the posture of the patient will govern or will control the intraocular pressure, as while the patient is sitting, then move to the supine position. This will cause a greater intraocular pressure rise. And again, this pressure rise will be much more in glaucomatous patient. Exercise can have a dual effect, so it can cause, according to the type of the exercise, like for example, like bicycling, it can cause decrease in the intraocular pressure. But in case of glaucomatous patients, this pressure can be greater, or the response can be greater, because this patient can after exercise can develop rise of the intraocular pressure. This is because that the exercise can increase the episcleral venous pressure, which is one of the factors in the equation of the Goldman equation that has a direct proportional relationship with the rise of the intraocular pressure. Also, the exercise can cause acidosis, as we know, due to anaerobic glycolysis. So this acidosis can has an effect on the aqueous formation. The lid movement itself has also an effect on the eye movement, as there's a blinking. So the continuous blinking showed that this eyelid will cause compression over the surface of the globe. This compression will cause the momentary increase of the intraocular pressure about 10 millimeter mercury, and this effect will be exaggerated with the hard squeezing of the eye. So this squeezing can cause the intraocular pressure up to about 9 millimeter mercury. So this is one important tip while you are examining your patient. So this patient shouldn't squeeze his eyes, otherwise you will have a false high reading. due to contraction of the extraocular muscles. Some intraocular conditions may influence the effect of the intraocular pressure, such as retinal detachment. So if there is a rhegmatogenous retinal detachment with a break and subretinal fluid that will pass under the retina, this will cause decrease of the intraocular pressure. So if there is glaucoma, this will cause elevation of the intraocular pressure, but if there is rhegmatogenous retinal detachment, then the intraocular pressure may be decreased. Other systemic conditions have been related to the intraocular pressure, such as the blood pressure. So it was found that the more the intraocular the blood pressure, the more the intraocular pressure. Also, hyperthermia show increase of the intraocular pressure, and the pregnancy, the intraocular pressure will be decreased due to the effect of progesterone. Diabetic patients have higher pressure usually, and the intraocular pressure will also maybe responded to different kinds of hormones like the growth hormone, and
Exposure to cold will raise the intraocular pressure.
general anesthesia. This has been asked before in the MCQ, so please concentrate with me. If we are this is important because even for the clinical, if you are going to examine a patient under general anesthesia and you need to measure his intraocular pressure, you need to know what is the type of anesthesia used, because general anesthesia generally reduce the intraocular pressure. So you need to measure the intraocular pressure as fast as possible once the patient is put asleep. But there are exceptions, like the trichloroethylene and the ketamine. All these agents will cause elevation of the intraocular pressure. So most of the anesthetics or most of the anesthesiology doctors, they know this information, so they usually don't use ketamine and the trichloroethylene for general anesthesia, as they should know that it causes increase of the intraocular pressure. Also, some agents like causing muscle relaxants such as succinylcholine and the succinylmethonium will cause a transient increase of the intraocular pressure. This is also important. Tracheal intubation will cause also rise of the intraocular pressure. So again, what are the general anesthetic agents that may cause rise of the intraocular pressure? This is the trichloroethylene and the ketamine, the succinylcholine, and the succinylmethonium. Some foods and drugs have been linked to increase or decrease of the intraocular pressure, like alcohol. So alcohol have been shown to decrease the intraocular pressure, but this is not an advice for you to be alcoholic. So this is just a coincidence to find that these patients who are alcoholic show decrease of the intraocular pressure. Even that this even in patients with glaucoma, this effect have been more pronounced. Caffeine, on the other hand, can cause transient increase of the intraocular pressure, as well as the tobacco smoking can cause transient increase in the intraocular pressure. On the other hand, the marijuana and the heroin or LSD, so these are narcotics, can cause elevation of the intraocular pressure. So again, the heroin and the marijuana can cause lowering the intraocular pressure, while the LSD can cause elevation of the intraocular pressure. And that's why it was now proposed that, well, why marijuana cannot be used as a treatment. So in some countries like Canada or Australia, they are now trying to manufacture this marijuana in a legal form, in a legal therapeutic form, like an eye drop, so that the glaucomatous patients can be using them. Steroids can be also can cause elevation of the intraocular pressure. So to summarize, this is the factors will cause high intraocular pressure and factors will cause low intraocular pressure. So what are the causes may increase the intraocular pressure? The genetic factor here. The age of the patient, the more the higher the sexes, so that the females are more prone if they are old age than males. Race more common in the blacks than in whites. Refractive more, the open angle is more common in myopes than hyperopes. Diurnal variation, so it will increase in the day and it will decrease at night. The hypertension will have been also correlated with the rise of the intraocular pressure. Hypothermia can also increase the intraocular pressure. The pregnancy as well. The caffeine can increase the intraocular pressure and the tobacco. But on the other hand, the marijuana and the alcohol will cause decrease of the intraocular pressure. Okay, so this is the end of our lecture today.
Rise.